distinct honor to be here today on the Monarch Arts and Wellness Foundation podcast. I'm Dr. Ryan Greene, one of the co-founders with Samantha McNeely, my better half, and we have the opportunity to speak to Darin Selnick, Mr. Darin Selnick, who is a senior advisor to Concerned Veterans for America, as one of the things that we are hopeful to do with this endeavor, initiative, my work, Sam's work independently, is to provide an opportunity for people of all walks of life, but specifically people with a background in the military. As an Army Reserve member myself, I can speak to the impact that our lack of just general health, wellness, access to resources has impacted people that have served us in such a significant way, whether we know it or not, and ultimately they need as much assistance as possible. So it's a cool opportunity to have you here, and I appreciate you coming and taking the time to offer your expertise. And we're just going to batter you with questions, because I think if anyone knows anything about what's happening at the top level where everything gets done, it's probably you.
Well, I appreciate it. Just so people know my bona fides, as they like to say. I also was the former senior advisor to the VA secretary. So, and I have many years of healthcare experience myself in some HMOs and medical groups as well.
Yeah, amazing. You want to lead us off?
Sure. Well, where to start? So, how I met you, right? That was the first time I met you was in a Superman outfit.
Gotta have fun. This guy's all serious.
So yeah, just tell me a little bit more of what you shared with me, like your whole background. It was really fascinating, just all the different things you were working on.
Yeah, so I actually started off in college as a health science major, and went into the Air Force and did nothing with health science. But that's the way it goes. But I am an Air Force retired officer. The healthcare that I use is from Camp Pendleton. I use a TRICARE system. Been involved in veterans organizations since the early 90s. Spent a good number of years in California for FHP Healthcare, which doesn't exist anymore, all the mergers. Medical Group, Lindora Medical Group, Pacific Care, and then had an opportunity to serve my fellow veterans by going into the VA in 2001. And so since then, I've actually did 9 years inside the VA in various positions, working with the Veterans Health Administration, but was a special assistant to 3 secretaries and senior advisor to 2. Was also on the Commission on Care, which was the 2015-2016 bipartisan congressional presidential commission about how to fix and improve the VA healthcare system. And then in 2017, 2019 was at the VA, where I was fortunate to be able to, it's called the Mission Act. It was the big reform improvements of the VA healthcare system. I was able to help write that, negotiate that, and implement that system, which just pretty much made it a more modern system like the TRICARE Prime system.
As someone who was a resident in the medical facility, in the medical system, I should say, in 2015, 2016, like I've seen it, but I was in Vermont, which I think apparently the facility in Vermont is kind of like a country club compared to most. So I don't know if I got the full experience, but I think with some of my colleagues who are combat veterans, Did you watch the documentary that I had come out on ESPN Plus?
No.
Okay, so I've been doing some work with special operators off-site in other countries, doing some work with plant medicine meets science, looking at ways that we can help individuals alternatively compared to what we have now. So I've seen it on both sides, and the general consensus is not that people are ungrateful for the VA system. It's just it's tough to navigate. So as of today, 2023, what would you say is kind of our biggest thing to navigate through, especially on the VA system side, that has to be addressed most urgently, especially mental health and the homelessness situation?
Yeah, the biggest problem for veterans is access. And so the VA still runs on an antiquated staff model, HMO type model, where they want you to be at their facilities and then for them to decide when you can see other providers. The problem with that is often you have months of wait times and you may have hours of drive times. The VA benefit, what we've been trying to get it to is like every other benefit and like every other federal healthcare benefit, where the patient gets to pick who is the actual provider of their care, rather than someone in a medical center saying, you have to go to this hospital, you have to go to this doctor, and we will make all the decisions for you. So the patient knows best what is the care they want, and that's especially challenging for mental health. You want someone who has mental health to be able to have quick access to someone that they feel comfortable with. Sometimes that's the VA, but a lot of veterans do not feel comfortable with the VA or any government health care because that's where they got their PTSD and their mental health issues, military sexual trauma, et cetera. So I know I've had female veterans say to me, I don't want to get my mental health at a VA facility because most of the population are guys and I had sexual trauma. I don't want to be around the guys getting health care for sexual trauma when that's where I got it from in the first place. So the problem with the VA is being both payer and provider is that it's got an inherent conflict. And then the payer side wants to take care of the provider side. And what we really want to do is what General Mark Bradley said, which was, put the bureaucracy aside and do what's best for veterans first, and the paperwork later. So that's where we're continuing to move to. Interestingly enough, DOD is the leader in this. I'm a DOD patient over at Camp Pendleton, and I got a notice a few months ago saying that if you need any outpatient mental health, you can just go to any provider in the network, and you don't have to get a referral and authorization.
Yeah, what's interesting is I've, as part of the offshore work and the onshore side of that, we've worked with a group called Revitalist, which is basically in the southeast for the most part, and they do ketamine treatments, and they have a VCA in place, so they're seeing a ton of veterans, and the agreement, it's basically like what you're saying, where it's the acknowledgement of this has been beneficial, the VA is not going to do it, so just go to our preferred providers, and it's worked out pretty well. The problem is like there's so many people that even with the out of network, so to speak, opportunities and arrangements, like they're still overwhelmed and they still don't have enough staff to service all the people that they need. So it's been interesting to see it moving in that direction, and I'm hopeful that that network continues to expand. But like, what has to happen to facilitate this alternative thinking, which, like, I agree is, last time I was in the VA, I was like, I'm stepped back into 1980. Like, everything that was there seemed backwards. They did have robots that delivered medication, but
well, what happened with the VA is that in the early 1990s, the new VHA Secretary Ken Kaiser, who came from California, brought the 1992 model of California managed care to the VA, and it hasn't changed since. I started working in managed care at FHP in 1993, so I recognize the model as the same one I had left a number of years previously. But in terms of your question, what has to happen is VA needs to follow the existing laws as they were written and intended in the regulations. So although VA can have preferred providers, the veteran is the one who gets to pick who that provider is once they're eligible for community care, whether it's in the network or a VCA. So the VCA was set up specifically so that if you had some sort of treatment that was not able to be in the network, that you could go, the VA could go ahead and specifically for that veteran have a VCA contract. It's called the Veterans Care Agreement contract. And that way, if you have something that's a unique skill set, or it's in a rural area where there are not a lot of doctors, dialysis is an example of something that's not normally in the network because of how dialysis is done. But that was to make sure that no matter what the medical issue is for a veteran, if it couldn't be in a normal network, there's always the ability to find someone in the country who could do it, and therefore do a VCA. But the key thing is there, the veteran needs to know and be able to pick the preferred provider. And if they're in the network, great. If they're not in the network, VA can do a VCA. But if VA refers, and that's the normal process, and say, hey, we think this is the best provider, you should go to it. If the veteran agrees, great. If the veteran doesn't like that provider and has another provider, then the VA should make sure they can go to that provider as well.
Is there a funding issue to get these agreements set up? And like, how do we navigate around that? Because it seems just like, it seems like every year we hit a debt ceiling and then we just keep raising it. And it's just like how do we get the funding for what we need from this standpoint?
So VA funding is fully funded. Community care is fully funded. If they were to actually run out, they're able to go back to Congress, and Congress will give them a supplemental. The community care budget is a fully separate budget than the facility budget, so one does not depend on the other. And so in terms of being in the community network, you go to the TPA. Out here is Tri-West. On back east is Optum. For veterans care agreements, since that's outside the network, you have to deal directly with the VA, but they have full authorization and full funding to do a veterans care agreement whenever the need comes to take care of a veteran.
Got it.
I'm curious. I remember you telling me some of the stuff that you're really proud of that you had like sort of accomplished for the veterans and the VA. I would love to hear more about that.
Sure. I served in a couple different administrations back in 2008. I was able to put together additional money for homeless veterans, support and families. And that program was put together because working with the homeless provider team, how do you prevent homelessness? You prevent it by either stopping a veteran from becoming homeless in the first place, much easier to prevent there, or what we were seeing was lots of veterans coming out of homelessness but going back in because they didn't have the skills. So we've created a new grant program to work with a community organization called the Supportive Services for Veterans and Families. And that's been a very huge success. So I did that in 2008. And then most recently, we want to make sure veterans have a VA that's accountable. If there happen to be bad employees, that hurts the veterans and it hurts the other employees. So we did accountability legislation so that bad employees could actually get fired. And then we did the Mission Act, which for the first time put into the law permanently, fixed a whole lot of issues. The processing of healthcare claims, making sure that doctors get paid. If providers don't get paid, they leave the network because they can only do charity so far. But then modeling it after TRICARE Prime. All veterans who use the VA come from the TRICARE system, and the TRICARE system works really well. And so the idea of having access standards so that if a veteran shouldn't have to wait more than 20 days for mental health or primary care, or 28 days for any specialty care from the date of the request, or it shouldn't have to drive more than 30 minutes for primary care and mental health, or more than 60 minutes for specialty care. So that's what the first time we put in there. And so many veterans at the time had to literally drive for hours to get to an appointment. And so some of the things that we want to improve on that, with new legislation that is coming out, which is called the Veterans Health Act, which is very bipartisan. Senator Sinema and Senator Moran on the Democrat and Republican on the Senate Veterans Affairs Committee are both co-sponsors in that bill. But it fixes a lot of the operational issues that they've been seeing, and it makes sure that all mental health, whether it's inpatient, extended care, residential, applies to those access standards. So basically every part of the benefit except nursing homes would have those access standards, so no matter what a veteran needed, they wouldn't have to wait too long or drive too far. The other thing we put in there is that best medical interest. So if a doctor sees with a patient that, hey, even though I'm very close or there's not a very long wait for whatever the care is, surgery, mental health, if they agree that for the best medical interest, you need to see this community provider because they are the tops in that field, or they have a special treatment that the VA doesn't use, or whatever that is. Through best medical interest, the doctor can put in a consult and get an authorization for a veteran for whatever is needed at any time. And we want to make sure that's properly followed because, unfortunately, a lot of doctors have been overruled by administrators when they put in for best medical interest. And for someone who comes from the health field, and you as a doctor, the idea that some administrator would literally overrule a clinical assessment of the doctor is absolute insanity.
It's insane. So follow up to that, even with these pieces of legislation, how well have they been able to be implemented? Because, for instance, when I have to get my, dental readiness exam, my PHA, like I'm literally sent to Irvine to go see a dentist. I'm like, can I not just go to a dentist? There's 1,000 literally within a square mile of here, and have them fill out a form. They're like, nope, can't do it. You got to go over here. So even though these pieces have been implemented, ultimately, how long does it take to actually have them functioning well, and or do they even get implemented at all? I say that because on the medical side, the common vernacular is anything that is introduced in the medical space today will not be fully adopted and utilized till about 17 years from now. And at that point, who knows if it's even valuable as a standard. So how would you say that these efforts and initiatives have been, one, adopted, and two, like actually implemented, especially the stuff that was done, early 2000s?
Yeah, I mean, I know exactly what you're talking about. We used to have that trouble in the HMOs in the medical group, where even if you had a new technology or new procedure that was to the benefit of the doctor, old habits die hard.
Very hard, yeah.
So, utilization and getting someone to adopt new habits can be very challenging.
So basically the generation has to retire and then the
sometimes.
new time come
But
through.
here we were talking, though, more about processes. And actually, for the first year, it was adopted very well. One of the things that I did was, besides in terms of implementation, I rolled up the sleeves and worked very closely with all the medical professionals in terms of the regulations, the policies, the training. I mean, I would literally flow diagram what's going to happen, what if things don't work out, how do we make sure it works. There was a lot of old, outdated operational bugs in the system. For example, many VAs are only using one exam room, and they don't have a secondary prep room. This causes a number of veterans to be seen to be dramatic. So it was working very well. The problem happened when COVID hit. And when COVID hit, most everybody shut down temporarily, and DOD's hospitals did as well. But the rest of the community opened back up quickly, because if they didn't, they would go out of business. And we were starting to see the effects of delayed healthcare. VA didn't open back up. DOD did much slower, but the difference between VA and DOD was that when DOD was shut down, they immediately would send you to the community. And then, because I, for example, needed a dermatology appointment, I thought I might have something on my arm that looked, could be cancerous, so I wanted to get seen quickly. They were shut down, but they said, hey, Darin, we're going to get you this authorization, and if for some reason they're shut down, you let us know, we'll find someone else who's not. Well, they weren't shut down. I got a visit in about 2.5 weeks, and this was at the height of COVID. All the private sector knew how to do all the protocols, the masks, the outside waiting room in your car, all that kind of stuff. But VA wouldn't do the same thing. They would sit there and say it's too dangerous for you. Studies later showed that it's actually more dangerous not to get seen. There was a study done that showed that across the United States, that for patients who got delayed care, 57% had negative health outcomes because of that. So VA actually got behind 20 million appointments because of that. And they were saying, well, we don't think it's not medically necessary, but they didn't think it was appropriate to go out.
Who's making those calls? Is it, to your point, is it administrators? Is it medical professionals? Is it?
It is not medical professionals. As a matter of fact, medical professionals are the ones getting in trouble for saying, hey, my patients have been waiting for 4 months or 5 months, and I got to have them seen. We're backed up for whatever reason, and I want to see them in the community. It's management. It's the administrators from the top down to the regional visit directors, to the medical management. And basically, once again, this is the problem when you have an inherent conflict between between parent and provider because the management's saying, hey, they're going to the community, which means down the road, they may not come back. And so they want to protect their staff model operations, their facility operations, to the detriment of the patient. DOD doesn't have that conflict. DOD, I hate to say they don't care, but what they care about is that you get seen. So they don't have any cultural influences and conflict between payer and providers sit there and say, oh, we got to keep them at Camp Pendleton or lose money or lose staffing down the road. So that's it. So that's been the big challenge. There have been FOIA documentations that I've been able to look at that show that management has put in training materials and guide illegal policy statements to override the law and the regulation. Literally, I've seen flow charts where a veteran who is eligible for community care meets the criteria, either access standards or best medical interests or the other criteria, and therefore is asked, do you want to go in the community? And they say yes. Seen them given to a referral coordination team. The referral coordination team is headed by a nurse and staff who do not know this patient. They only have the file. And so once you're eligible for community care, once you say you want it, it's supposed to be a 2-day process to go ahead and turn that into an authorization and contact the veteran. Instead, they send it to a referral coordination team, and that referral coordination team would make their own judgment. And if they decided they didn't think it was appropriate for you to go in the community, they would literally overturn the doctor, the veteran, the law, and the regulation, and then they would contact the doctor and say, you know what, we're canceling your consult, we're canceling your clinical judgment, and we want you to go ahead and figure out a treatment plan in the facility regardless. This has caused untold amount of veterans, because we don't have the data on it, to be denied community care. I get the calls from them and the stories from them, and the members in the Hill are getting those stories as well. But I've seen the actual documentation that tells how to do it, how they flowchart it, what they tell veterans, and those sorts of things. So many veterans who are eligible, like dental, if it's an access standard that applies to dental. The veterans are literally told to drive hours when they're not supposed to be. They're told to wait months, and sometimes when they're actually are allowed to go in the community, it can take them several months before they are actually notified of it. In the DoD system, as in most modern healthcare systems, you're able to go online and look at things like your authorizations and your claims and your EOB. VA has purposely not done that to keep the patient in the dark. I know that because I put together the initiative to do the same thing that DoD has, and once I left, they scrapped the initiative. So a veteran can't check their claim, they can't check their EOB, they can't check the status of their authorization. And even though there's an official appeals process, it's very hard for them to literally even get the denial in writing, if you can imagine that.
Who wins by doing this? You see, you know what I'm saying? Like, just like what?
Like, what's the point of trying to not make care access?
I get it. Yeah.
Ultimately, nobody wins.
Then why? Like, why are we making it so difficult?
Here's what I've been told by staff, and this is based on how the budgets. So the community care budget and the facility budgets are two separate budgets. They were done on that on purpose so that one budget wouldn't affect the other. However, each year, VA does its own form of capitation. And in that form of capitation, although VHA gets a total budget that's not based on capitation, they just get a budget, and they tell Congress, hey, we have these, we think we're going to need an extra 3 or 4 or 5% or whatever increase based on inflation. So they get a total budget. But internally what happens is, and that a total different budget for community care, but internally with the internal capitation, what happens is they do a look back and they say, okay, for the last year, how many patients did you have last year that actually used your facilities? And how many patients, is that an increase or a decrease? And they do that by primary care and by specialty. And so if over the last year you have a number of patients have fallen, and a patient only has to have used you one time to count. So if the number of patients have fallen in a specialty or primary care, then that medical facility, as you would expect in any healthcare business, would lose funding because it's based on the number of patients you have. Because they want to make sure they don't lose any patients, they have a recapture program. And so what I've been told is the management views this as us versus them, community care versus us facilities. Every patient that goes to community care is not a current dollar, but a future dollar that comes from us. So they want to keep their money, they want to keep their staffing, and it doesn't matter how few patients they have. And what can be very dangerous of this is not that it becomes very, very expensive. In the VA budget, for example, they're looking to spend in 2025 about $21,000 per patient per year. Very, very expensive, especially when those patients are not even full-time. But that's what it's about. They want to keep their money. That is, the management is more important to them to keep the institution going the way they want it than for patients to get the treatment in a timely manner. So it's very sad. The patients lose out, the doctors lose out, and ultimately what it causes is a drive for to change the system so that the management can't get in the way.
Do the because when I was a resident, I had to be there, so it was what it was.
Mm-hmm.
How are you finding? I guess what's like the critical juncture where you kind of hit the terminus in terms of, all right, this system is not only, because if I was in that system as a provider, like unless I was there collecting a paycheck and didn't care, which is, it's hard to imagine most practitioners would be like that, but where is that point, that critical breaking point where it doesn't matter what you're spending in terms of patients, like you're losing nurses, you're losing providers, because they're just like, why would I work here versus going over there? Better technology, better management. Like how far away are we from that? Because I just keep hearing that in the general population space, we are rapidly approaching this point where like the cost of taking care of the general population is going to exceed what we have in Medicare, Medicaid, Social Security. What does that look like, and how close to, I don't want to say collapse, but just like a critical dysfunction where regardless how much money you have, you don't have people that are going to serve the patients. So at that point, it doesn't matter.
Yeah, it's not a money issue. It's for anyone who's done healthcare operations, it's reached that breaking point right now. So I get calls from dedicated nurses, dedicated doctors, dedicated community care staff. They tell me what's going on. I'm trying to work for them to get to the committees to tell their stories. There was recently a hearing where Independence Fund, Wounded Warrior Project, and Miramar Health as a provider each told their stories about how dysfunctional the system is. So you can have as much money as you want, but if you have dysfunctional operations, let me give you an example of dysfunctional operation. So as I talked to a doctor the other month, she was telling me how she was getting beaten up because she was putting patients into community care, and she was doing that because they had 4-month, 5-month, 6-month wait times. So I was saying, well, what is going on operationally that you have such long wait times? And so I asked her, I said, well, how many patients a day are you even seeing? And she said, I'm only seeing 6 patients a day. And I said, well, how is it possible you're only seeing 6 patients a day? Just for an equivalent standard, although it's higher in the private sector, DoD hospitals see 19 patients a day. Yeah. Okay, VA has never been good. They used to see 10 patients, but to see 6. So how does that work? That you can only see 6 patients a day? Well, when operationally you sit there and say, well, we're gonna use one exam room. That's it. And the nurse is going to have a half hour with the patient. We're going to do 6 one-hour blocks. That's it. 6-hour blocks of the day. The RN gets the first half hour. The doctor gets the other half hour, and that's it. So the doctor physically can't see more than 6 patients a day, and because you're only using one exam room, the doctor 30 minutes is a lot of time for any patient.
Totally.
But if that's what you needed, you would have another exam room and another patient ready to go, and then you would move on until at least you could see 12, right?
Yeah.
But they don't use 2 exam rooms. They only use the one, 30 minutes. And so then I ask, well, what are you doing for those other 30 minutes, when you're not seeing patients? Because look, if you're seeing 6 patients a day, you're only seeing patients for 3 hours a day. What I'm told by the doctors, mindless, low-level administrative tasks that in any other medical organization you have, admin assistants or lower-level nursing assistants and stuff like that to handle all. The doctors shouldn't be faxing. So
No.
in other healthcare organization, what is the most precious time? It's the time of the doctor. And what is that time supposed to be used for? Seeing patients. And so any administrative task, whether it's a computer task that can be done by somebody else, prep time, you go through, and when you do healthcare operations, you go through this all the time in terms of utilization. What is something that we can take off the doctor's hands that they don't have to do so they can see patients and they can do what they need to do with the patients? VA doesn't do any of that. And so they're down to literally 6 patients a day.
That's unbelievable.
Yeah, and so money doesn't fix that. That's
Yeah.
not the problem.
Yeah.
Money's not the problem. Basic understanding and basic utilization of basic. When I was at FHP with our hospitals clinics, and I was in charge of the center manager training program, we always had 3 exam rooms.
Yeah.
And they were coded, and they were, we were always going through. We were always going through with our doctor utilization teams, our clinician utilization teams, to see how we could do better, and to see how we could always not cut corners, but manage costs appropriately. Utilization teams say, okay, is a particular doctor prescribing outside the norms? If they are, why? Was it medically necessary? Do they understand the difference between, a generic and a non-generic, and are they the same? And this is all the stuff you learn, because some formularies, some generics are literally the same bottle and the same assembly line. They just happen to go over. That can or cannot be the case. So you learn all this. So how do you be the most efficient with the money, and how do you be the most efficient with the time, and still making sure that you have plenty of time to see the patient when you see the patient and do those sorts of things. VA doesn't do any of that anymore. Instead, it just says, I want more money. And then it's, for those who are familiar with RVUs, VA's RVUs are a reflection of his inefficiency, not the reflection. So the more inefficient they are, the higher the RVUs go.
What is an RVU?
Relative value units. It's a way to calculate if you have a book of business, can you afford that book of business? How efficient are you?
Yeah, like surgeons depends on the hospital, but you're basically graded based on how many RVUs you do, which is how many procedures, how many implants, how much did you make. So it's and I've seen clinicians get fired because their RVU rates on an annual basis weren't high enough. So it's just like a sneaky way to set like a quota. Like, what's my quota for the year in terms of RVUs? So yeah, it's
VA has totally flipped it on its head, the
Yeah.
concept, as they do other terms.
Yeah.
And to sit there. So yeah, if you have less patients, because VA has less patients each year, and the overall number of veterans in the country is declining, and the number of patients enrolled in the VA system is declining. The number of patients, only 2/3 of the patients enrolled actually use the VA system, and that number is declining. So you have to say to yourself, if the number of patients that use the system is declining, and you're giving it a lot more money, that's when you see the RVUs spike up, because it's really a reflection of the inefficiency, not the efficiency. It's a weird transposition, and I have to explain it to people, but
That's wild.
People in the healthcare field, they just see a number that the VA throws up, and they go, oh my gosh, your costs are going up and all this stuff like that, and you need more money and more staff. So if you have a broken operational system, you can throw as many staff as you want.
Sure.
But that's like having an automotive assembly line where you just are handcrafting every part
Yeah.
yourself.
Yeah, you're just painting layers of paint on paint on paint, just trying to fix the problem. So does it need to collapse before it can get better, or what do we need to see happen? Because I think it's the metric I've seen most recently is like every 22 seconds or 22 minutes a veteran commits suicide. Like, what has to happen to really, in your opinion, like, not the buttoned up political answer, so to speak, but like, what do you think really is going to have to happen before we see some change?
Well, unfortunately, I think Newt Gingrich framed this up correctly from his time as Speaker, and that is Congress never does anything it needs to unless there's a crisis. There is a crisis at VA right now. It's a silent crisis, and so one of the things that I do a lot is work with media to get the crisis out there. I just did an op-ed that was on the Hill. I've gone on Fox News in the past, OAN, podcasts like this, David Webb Show, Sirius XM, to get it out. I'm working with the House and the Veterans Committees, so to get the word out through testifying for veterans, community organizations, and to get the whistleblowers, their testimony out as well. Veterans are red flagged when they speak out loudly. For those who don't know what red flag means, it means you're identified as a troublemaker, and you get treated very poorly in the system.
Oh, wow.
So if you think of one flew over the cuckoo's nest, that's what you're talking about. And I know this because veterans get a hold of me, and I literally get on the phone with the VA with these veterans who've been red flagged.
Wow.
And they can't talk any nonsense to me, because if you're the one who wrote and implemented the law and the regulation and did the policies, they can't. I know it better than they do. So I quote it, and then I get them to do what it's doing. But to answer your question, we need the media spotlight on it. We need as much media spotlight on what's really going on. I mean, you've seen some positive change in the West LA area with homelessness, because once they started doing some of the media spotlight on homeless veterans camped out in front of the gates of the VA, then they started to do something about it. Legislators the same way. We have some bills in Congress that have been introduced or about to be reintroduced that would basically modernize the VA healthcare system, just like any other managed care system, so that the veteran could pick any provider of the network without the need for access standards. So if you think about this, if you're on Medicare and you've got a Medicare Advantage, or you just on Medicare, nobody tells you what doctor you have to go to. Nobody tells you what hospital. You go ahead and pick. And if they don't provide good service, you pick somebody else. So we do that in VA with urgent care. If you have urgent care, when we did the Mission Act, we made that so that was what I call full choice. You can go to any urgent care provider in the network, and you just go straight there. They confirm your eligibility, they take care of you, send the bill and the records back to the VA. We want to do that with the rest of the VA healthcare system. It was actually a bipartisan recommendation in the Commission of Care that I was on in 2016, signed off by the previous Obama administration, just never implemented. So we have Senator Blackburn in the House, and Rosendale, Representative Rosendale and Biggs in the House, and Senator Blackburn in the Senate, who have bills to do just that. Basically, what that would mean is that you just have one big network. VA would be another provider in that network. And if the VA, if you wanted to go to VA for your primary care, you'd pick VA. If you're at VA and you want a different specialist, then you'd pick the specialist network. Just like any managed care, healthcare, HMO type organization, where you have one big network and you pick, you do what any rational person does. You read what reviews you can, how close. Maybe call them up, see what their wait times are. Do they have open and closed panels, whatever. Yeah. And then if that works for you, great. And if they take a long time and you don't like the wait times, you pick somebody else. Totally. That's what the intent of the legislation is to make VA have to compete for its veterans' dollars. And if you compete, then you will either improve or you'll suffer the consequences. But the veteran shouldn't have to suffer the consequences of antiquated healthcare organizations that have no interest in improving wait times, quality, or customer service, because they'll continue to get funding regardless. In the private sector, if you don't adjust to your patients, then ultimately you go out of business because they will go somewhere else.
Is that the legislation that you're working on in DC currently?
I work on lots of legislation. So the Veterans Health Act, the bipartisan, which is to basically what I call what it does is everything that we've identified that VA is not doing in following the law or creating policies that go around things like the access standards, the law fixes that. But in the long term, and that's good because that will improve things, it also does a pilot for full choice for mental health. Mental health is probably, in SUD, is probably the most crucial area because it's the most critical life-saving area. And I've always had this, when I was at VA, I always had this problem Because when I would ask the question, even if you were the best mental health provider, and even if the veterans wanted you at all times, you basically only open an 8-hour day.
Mm-hmm.
So what do you do with veterans who have mental health situations and problems the other hours of the day? Well, we send them to emergency care. Well, it's very unfortunate, but many veterans have literally blown out their brains
Mm-hmm.
in emergency care rooms because they haven't gotten treatment or they waited so long. If you need your mental health, you've got to get it as soon as possible. You've got to get it with who you're comfortable with. And for, only 6 out of 20 veterans will use the VA healthcare system, and that's because the rest don't want to, not because they don't need to. And it's lots of reasons, whether it's clearances, government, or bad treatment.
How much money do you think it would take, so kind of what that stimulated in my mind,
Mm-hmm.
and I don't know if it's stimulated in yours, is like, if you created a separate entity, completely, private, whether it was privately funded or whatever, how much money do you think would be necessary to be raised? And I say that just because with the purpose of what we're doing here is like, it's not unreasonable to say, hey, you may find someone who's going to offer a couple $100 million, just be like, build a hospital that's basically VA private, but it's nicer. Like, I don't even know if you have a number, but realistically, like, what kind of funding would be necessary to set up kind of like a competitive, privately funded, not-for-profit system that could help, so that we don't have this issue, which is like turfing people to other care.
Yeah, I mean, we've proposed some of this in the past, and we ran some numbers. If you really want to modernize the system, you've got to separate the payer and provider functions. So VHA, the health administration, should just be the payer. Okay. The best way to modernize facilities is to get them out. There's too many federal government restrictions. Is to basically make them a nonprofit government corporation. If you made them a nonprofit government corporation, then not only would they be able to, how do I want to put this, be free of all the federal regulations, but the problem with the reason why the staff models died out is because when you have hospitals, you have to be able to fill those hospitals. There's not enough veterans to fill the hospitals, even if they were the best hospitals. So they're very inefficient. That's why, like FHP, it took its hospitals and its clinics and spun them off into a medical group, so we could take patients from every HMO and every source. VA needs to be able to do that facility-wise in order to actually compete and have the ability to downsize facilities it doesn't need and lease operations and stuff like that. So that's one part. We did the cost analysis on this back in 2015, and it would actually be a cheaper operation. We do know by comparison with the DoD TRICARE Select that if VA was a payer and simply the VA facilities were part of a large PPO like TRICARE Select, that DoD's PPO for all healthcare, because I read the numbers, is over half cheaper than the current way they're managing it. And it makes sense because you're not having to do the expensive facility operations, especially when you can't keep those facilities filled. So as an illustrative example, there was a market assessment done for a smaller hospital type facility in Montana. And so they did an assessment just on specialty care, in-house specialty care. Because of the low patient flow in the Fort Harrison area of the number of veterans versus the providers, for the specialty areas they picked, it cost VA $25 million to provide these select specialty areas with the number of patients. The private sector, for the exact same number of patients in the specialty areas, would only cost $14 million. And why was that? The note was that Fort Harrison was a 63-year-old facility. It was past its useful life, number one. Number two, the facility was very expensive to maintain. And number three, they had a low flow of patients. So every drop in patient means the cost per patient increases. So, in that case, you could be, having total community care. The veterans would be getting it closer to where they are because they'd have that network of providers in the area rather than just one centralized location. The veterans could, pick between the providers they like the best, so they'd have quicker access overall. And it would actually, that's savings that you could apply to something else. No different than mental health, SUD, or other things throughout the system.
It stimulates a lot of thoughts in my head about how could we just raise money and create kind of like our own adjacent system that either forces them to.
Well, I mean, the key thing is it's you don't have to create anything new. You just have to let the veteran be in charge of their benefit. So let me give you an example. Every other benefit that the VA has for veterans, they are in charge. So the GI Bill, for example, you pick any university or college you want. Okay, the VA doesn't tell you what college or university to go to. It should be the same thing with healthcare. You can do it by having a network. That makes a lot of sense. And then you can have the non-network stuff like the VCAs, but basically that's what we're driving it to is say, put the veteran in charge of the healthcare benefit. You served your country, you fought overseas, your toxic exposure, PTSD, whatever. Only the VA is the only socialized healthcare where you're not in charge of your benefit. Medicare you are, and the way I explain this to staffers is, could you imagine if Medicare put out a letter to all Medicare recipients tomorrow saying that as of next month, to receive your Medicare, Medicare will now tell you what hospital you will go to. Medicare will tell you what doctor you have. And if you don't go to that hospital and use that doctor, you don't get Medicare. Who in this country would accept that?
No, you'd have an uprising of geriatrics marching.
Exactly, but somehow it's okay for the veterans not to be in control of their benefit. Well, they're in charge of every other benefit. And in DOD, they're in charge of the benefit. If I don't like the DOD hospital, I can go ahead to TRICARE, go over to TRICARE Select and have the PPO.
Who's standing in your way of like clear? This seems so clear cut to me, which is like, okay, just change it and just like if someone wants to, who's standing in the way?
Well, you've heard of the military-industrial complex?
Yes.
Yeah.
This is not it, but there is a similar complex. When you have an agency that spends $300 billion, there's a lot of people who don't want any change because they've got their hooks in there and they want that money. So there is an equivalent of a veterans benefit and healthcare complex, and anyone who's already got their hooks in the money doesn't want it to change. The leadership of the organization, they don't want to take the chance of losing anything. The vast majority of the employees are in the unions, and the unions see it as as an opportunity to recruit, so they don't want to lose any union members. And then there is a segment of very progressive members on the Hill who are for socialized healthcare, and they've written. I mean, I don't make this stuff up. I just read and find out what I find out. I've read the articles where they believe that that the entire country should be socialized healthcare, and if they can just prove it out at the VA, they can expand to the rest of the country. The problem is socialized healthcare doesn't work, and VA is a perfect example of it. And the excuse is that, well, if you just give it more money, and you just don't have the right management, it will work out. Well, it just continues to get worse. So, I mean, those are the big things. And then the other thing is just ignorance. Most people just have no clue how the VA works, how healthcare works. And, I like to say, because I've done this, I've worked with some really top healthcare leaders on all philosophical fences. I worked with, on the commission on Toby Cosgrove with the Cleveland Clinic, Nancy Schlichting, who ran the Henry Ford operation. And you take anyone who knows healthcare. I mean, I could sit down with you over lunch because you know healthcare. You take anyone who understands how healthcare runs, and you could draw on a napkin over lunch what needs to happen. It's not rocket science. It's not nothing unique or new. It's just the political will to take a system that grew up by accident in the 1930s and 40s because there weren't nationwide healthcare systems back then, and there was millions and millions and millions of veterans coming back from World War I and then World War II. That accident of history has been, with the government, it's hard to undo those things. And so it's just the political will and the understanding and keeping the veteran at the focus of what needs to happen, and not worrying about, is this institution going to happen, and really getting VA healthcare back to its core mission. And its core mission is service-connected and combat veteran focused, because other people may do that, but is it your primary focus or your secondary focus? For the VA, that should be your primary focus, is the service-connected combat, things like toxic exposure. That's why you have the research. But primary care, anybody can do primary care.
Yeah.
Anybody can do dental, anybody can do dermatology. The other things are the things that are important. And when you try to do everything, you end up not doing anything well. And that's pretty much what's been happening.
So just thinking about it, it's like, is there anything anybody could do to help that's like not you or like somebody with a ton of money, right? Like how does like just someone listening go, what can I do to better this situation?
Well, I will tell you what some very wealthy people have done. You're probably familiar with the Cohen clinics.
Mm-hmm.
Well, you take a billionaire whose son served in the Marines and saw his son's buddies have problems, and guy puts out $250 million to set up his own clinics, provide free service. So if the VA won't do it or can't do it, you have someone like that putting out a lot of money, building 30 clinics around the country. We have one that recently opened up in Oceanside and one here in LA, providing free mental health for veterans and family members, because VA cannot do it legally for family members. But ultimately, what we need, besides people doing VA's job for them, is really putting the spotlight, the media spotlight on this, and working with their legislators from both sides of the aisle to get them to say, hey, we've got to do what's best for veterans, not for government institutions. And what's best for veterans is the ability for the veteran to control their health care and pick who is the best provider, whether that's mental health side. The reason the VA homeless, and I'm on the New Directions for Veterans Homeless Board, the reason that the veterans homeless programs work so well is because it's all grant-based program. I mean, whether it's New Directions, Grant Per Diem Doe, the other grant program I mentioned earlier, Supportive Services for Veterans and Families, these are all grant programs. It is organizations that singular focus is to serve that community. And when they have that singular focus, they do it. Bureaucrats are good at spending money, but they're not good at services. They're not good at operations. That is why the government generally does not do services or operations. And the two that people are familiar with and complain about are the post office and Amtrak. So that's why government is a payer and not a provider. That's why they don't have, government colleges and, stuff like that. I mean, the federal government doesn't sit there and say, I'm going to give you a GI Bill and you're going to go to the VA college. It's not good at that. You need those other market forces and service focuses and accountability to make sure you have got customer service. And at all times, whether you're a veteran or whether you're just a regular American getting whatever service you get, you need to have the ability of competition and choice. And I say, there's nothing unique about government with a monopoly. If you went to a small town and there was only one gas station, what do you think the prices would be?
Yeah.
What do you think the service would be? All monopolies like to beat monopolies, and all monopolies end up providing. That's why they broke up Ma Bell, right? That's why you break up monopolies.
Well, it seems like a good place to wrap it up. But Darin, if people want to reach out and find more out about you, where can they find you on our interweb?
Well, if you Google me, unfortunately, too much will come up. But you can go to, I am a senior consultant to Concerned Veterans for America, so you can go to cv4a.org, and my bio is up there, and you can reach out to me there. That's a good spot. But my last comment on that would be, all of you who are watching this, you can do something. You can work through CV4A, or you can just work through your local veterans organization and contact your local congressman or senator's office and say, hey, I want what's best for the veterans. I want them to be able to control their health care. You need to support that kind of legislation.
Amazing. Well, thank you for joining us today. I really appreciate it, coming in on a Saturday.
Thank you.
And, we'll keep in touch, and hopefully with what we're doing with the foundation, having events, we can contribute to all of your initiatives and endeavors. So thank you again.
Great to be
you.
here. Thank you so much for having me.